Welcome to this early breakfast session on sexual health and cancer. And thank you for joining us, making this excellent choice of joining us for this session. Until recently, oncology has been mainly focused on dealing with the treatment of cancer and survival of the patients, naturally. But as survival has improved over the last decades, more and more people are living and living longer after their diagnosis. So we need to focus more on minimizing long-term side effects and increase quality of life after diagnosis and treatment. And we are getting better at this. We are dealing quite well with preventing cardiovascular disease, bone loss, infertility. But we have known for quite some time that there are great sexual problems in our group of patients, but we have been somewhat hesitant in dealing with them. But that is going to change now, and good things can happen. And the first speaker is going to tell us something more about that. I'd like to welcome Vilhelmína Haraldsdóttir, the Director of Medicine at Landspítalann, and she works as well as a specialist in hematology. Gjörðu svo vel.
Takk fyrir. Þetta verkefni Kynlíf og krabbamein samstarfsverkefni Landspítala og fyrirtækjanna Novartis og Sanofi Aventis. Við erum í þeim vandræðum hér á Íslandi að fáir þú krabbamein að þá eru hér eiginlega einna bestu horfur í Evrópu. Þetta hérna ánægjulegt og við höfum fylgst með þessu í gegnum tíðina og séð að hvernig lífshorfur hafa meira en tvöfaldast frá árinu 1954 og krabbameinsskráin skráir mjög vel hlutfallslega lyfin á Íslandi og þið sjáu hversu ánægjulega góð hún þó við viljum alltaf setja markið hærra. Í árslok 2008 þá voru 10.521 á lífi sem hafa greinst með krabbamein á Íslandi og þessi tala eykst alltaf jafnt og þétt. Og við höfum mikla skyldur við þessa einstaklinga. Þá það að það skiptir ekki einungis máli hversu lengi fólk lifir og 5 ára lifun og 10 ára lifun eru allt mikilvægir hlutir. En hins vegar það mjög vel þekkt að lífsgæðin, það skiptir miklu máli að viðhalda lífsgæðum og þar kemur kynheilsan og kynlífið beint inn í og óbeint á margan hátt. Stundum hættir okkur til Íslendingum að segja sem svo að þetta sé ekki svona á Íslandi, það sé bara annar staðar sem að hlutin eru svo og svo. En hér höfum við upplýsingar sem að beina okkur á það að hér á Íslandi sé það akkurat sama að við þurfum að huga mjög vel að þessum lífsgæðum okkar sjúklinga. Þórunn Sævarsdóttir, hún komst að því í sinni meistararitgerð að yfir 50% sjúklinga í krabbameinslyfjameðferð höfðu kynlífsvandamál og að þegar lífsgæðavíddir voru skoðaðar þá komu kynlífsgæðin verst út við upphaf meðferðar og eftir 3 og 6 mánuði. Nanna Friðriksdóttir hefur skoðað líka hvernig viðhorf sjúklinganna og það alltaf helmingur sjúklinga sem telur sig hafa fengið of litlar upplýsingar áhrif krabbameins á líkamlegt útlit, kynlíf og samband og hjónaband og þriðjungur myndi nýta sér sérhæfða ráðgjöf. Og síðan vitum við að starfsfólkið okkar, það oft vill gjarnan fræða sjúklingana þessi mál en skortir þjálfun og þekkingu. Þannig komum við að viðfangsefninu í dag. Þetta hefur lengi verið í umræðunni hjá okkar heilbrigðisstarfsfólki og þegar hópur fór á ASCO, þing bandarísku krabbameinssamtakanna 2010, að þá fór að þróast hugmyndir og eftir það urðu umræður við lyfjafyrirtækin og það var gerður samningur og Landspítalinn leggur til húsnæði, verkefnisstjóra og vinnutíma starfsfólks til framgangs markmiðum fyrirtækisins en Novartis og Sanofi greiða laun klínísk sérfræðings sem að vinnur að verkefninu sérstaklega. Við ræddum þetta hreinskilnislega þegar við gerðum þennan samning og eitt af því sem við ræddum að ráðgjöfin verður að vera hlutlaus og að hugsanlegum lyfjum á vegum þessa fyrirtækja yrði ekki hampað umfram önnur þegar færi farið að gefa sértæk ráð. Nú, út á hvað gengur verkefnið? Að fræða og þjálfa þá sem koma að lækningu og hjúkrun krabbameinssjúklinga þannig að umræðan kynlíf og kynheilbrigði verði sjálfsagður þáttur í meðferð sjúklingana. Það verði ekki hoppað yfir, hvað var það, blaðsíða 87, hérna fyrir þá sem muna eftir þeirri ágætu kennslubók hérna. Og að krabbameinssjúklingum standi til boða sérhæfð ráðgjafa þjónusta klínísks kynfræðings. Nú, staðan í dag þannig að þetta eiginlega upphafspunkturinn að það búið að hér að setja í gang fyrirlestur og vinnusmiðju. Jóna Ingibjörg Jónsdóttir, hjúkrunarfræðingur og klínískur kynfræðingur, hún hóf störf á Landspítala 7. janúar 2011 í 20% starfshlutfalli. Nanna Friðriksdóttir, sérfræðingur í hjúkrun, verkefnisstjóri. Við höfum myndað stýruhóp, verkefnishóp og tengiliði inn á helstu deildir og einingar. Og þau svið sem hafa komið á þessu á Landspítala eru fyrst og fremst lyflækningasvið, skurðlækningasvið og kvenna- og barnasviðið. Það er búið að gera verkefnisáætlun og við ætlum að fylgja þessu vel eftir og það verða kynningafundir á deildum Landspítala. Og það eru fyrirhugaðir kynningafundir hjá sjúklingafélögum og þar að auki komin bloggsíða í anda dagsins í dag. Nú, ég veit að þið getur fengið nánar upplýsingar hvernig hægt að senda beiðni til Jónu en það ýmsar leiðir til þess og ég held að sé ekki tíð til fyrirstöðu að fara að senda að beiðni og jafnvel þó menn sé í vafa hvort að það eigi við eða ekki, þá verðum við bara að læra reynslunni og láta verkefni þróast. Nú, við höfum fengið hér í dag góðan gest til þess að kynna hérna okkur betur þetta verkefni og veit okkur frekari leiðbeiningar. Og ég veit að Ásgerður hún mun kynna hann aðeins frekar en Nanna og Jóna hafa verið í sambandi við Woet og hann hefur óskað okkur til hamingju og bent okkur á það að við getum verið bara stolt af því sem við erum að gera og við séum í raun og veru ekki að gera neitt lúxus eða veita neitt lúxus því að þetta sé bara merkjum góða þjónustu að huga að kynlífi og kynheilbrigði. Takk ykkur fyrir, gjörðu svo vel.
It's an honor to introduce Dr. Woet Gianotti from the Netherlands. Dr. Gianotti started his early career working in tropical medicine in Africa and gynecology, surgery, but then most of his working life in sexual health and psychotherapy, and has a vast experience in the field of sexual health and cancer. Please, Dr. Woet.
You see, I have two different jobs in myself. I'm both a doctor and a psychotherapist. That means I know a little bit about down there and a little bit about up there. What I want to start is to tell you a little bit of the experience I got over the last 3-4 years. I'm in this field now for 35 years, but still when you see a lot of people and you discuss a lot of things, then you discover new elements in your job. And what was striking for me was in the last 3 years, two things which I want to give as a start for this lecture. One is I'm working in physical rehabilitation. That's in a unit where we get people after a stroke or after a spinal cord injury or people with traumatic brain injury. And then I'm sitting with a couple and they are married, for instance, for 35 years. And then after my process of treatment with them, I realized that at least 25% of the time I'm busy with them talking about the difference between male and female, explaining that they are not the same, the man and the woman, which is a little bit strange that me, being an outsider, is talking to people who know each other day and night already for 35 years. So in a way we make a very big mistake in the education of our children, that we don't tell them that there is really different and how to deal with the difference. And I know from my own past, let's say 30 years ago in the Netherlands, because I'm from the Netherlands, and I guess it's not so very different from here, feminism tried to explain that there is no difference. If you give the girls dinky toys and you give the boys dolls, then one generation and everything will be the same. I don't think that's true. That's one thing I want to give you as a starter. The second, I forgot the second. What was the second? Oh yeah, the second was about the difference between one person and another person. We're going to talk sex today, and talking sex is always, it's a little bit emotional, it's a little bit difficult, because we know a lot about body, we know a lot about behavior, we know a lot about sexuality that we believe, but we don't know very well what is my personal sexual behavior in relation to the behavior of other people. So it's very difficult to step out of your frame of reference as a professional, out of that frame, and out of the frame of the person, emotional, into the frame of the professional. Because the sex you have, that's okay. I hope so, at least. But that doesn't mean that what you have is the same for your patients. To give you a slight difference, I meet people and they say, yeah, it's right, it's already 6 or 8 weeks ago. We should do it once again. That's for some people not abnormal. But working in physical rehabilitation, I meet patients who've got, for instance, a traumatic accident, and they get into the rehab center, and then within 2 weeks, I'm called, please, can you discuss with Mr. Such and so, because he has big problems. And then I'm talking to this man, and he says, I can't sleep. Going to the sexologist, because you can't sleep. Yes, I can't get an orgasm, because 3 other people are in the room, and nurses walk in and out. I can't masturbate there, and I can't sleep if I didn't get an orgasm. And his last 30 years, he never slept without having an orgasm. So for him, orgasm every evening is a way to fall asleep. It's not abnormal. So between the man or the woman who does it once in 8 weeks and the man or the woman who does it once every day or even twice a day, there is a big range and a big variety, and we have to think about that. That means when we switch to patients with cancer, or when we switch to people who are very ill, or people who are going to die, or people who are lesbian, or people who are single, we should not think, oh, single, no sex. Very ill, no sex. Going to die, no sex. Because you don't know if that was a person who had sex once in 8 weeks, or a person for whom sex was very important to do it every day, kind of a way to recharge his battery. So try to keep in your mind the big variety of people. If not, maybe you lose the track today. Okay, let's start. First, I have to tell a little bit. I have a little bit connection to the financial industry, to the pharmaceutical companies. I work for Bayer, giving presentations on hemophilia, that's the bleeding disease, and on multiple sclerosis. I don't do research for them, but giving presentations to tell doctors how to deal with sexuality. Okay. For this morning, I want to give you a little bit an introduction on sexuality, on gender, and on more of a general approach. I want to tell a little bit about cancer and what cancer is doing to people, and a very little bit about what, when you've got a sexual problem with cancer, what we can do. And because in, let's say, 30 years ago, and some of you will know the old Masters and Johnson way of sexology, when you didn't have good sex, then you had to learn at least 5 or 6 different positions, and then it was okay. That's not the sexology we are dealing with nowadays. We have learned in our field an extremely big amount of new developments in terms of medication, tools, toys, relation treatment, cognitive treatment, morning treatment. We have a very wide range of possibilities, of strategies. So when you get a problem in one of your patients, don't be afraid to send the patient to the sexologist, because we can really do something. So the worry, I shouldn't ask about sex because then what to do, that should not be a problem for us. We can do it easily because we can do something for the patients. First about the numbers of cancer. This is from Holland, but I guess it won't be much different from here. If people get the diagnosis, then you get in a process of treatment, and after the treatment, a process of recovery. This is roughly 0.1% of the adult population. So if you have 1,000 Icelandic adults, about one, is that true? Yeah, one who is in treatment or in recovery for cancer. If you've got through this, then you can be happy and you can be survivor. And that's about 4% of the adult population is a survivor of cancer, so which is quite a higher group. And there is, of course, also a small group who does not get treated and gets in a sometimes long, sometimes short period of palliative care and finally a terminal phase, and then they die. That is about 0.2%. So altogether you have 4.3% of the population who is having or having had cancer in your society. I guess it's more or less the same. So here you see what happens in many situations, at least in the past, at least in the major part of the world, at least in a big part of the Dutch doctors, that they are scared to talk sex and they put it under the carpet. We shouldn't do that. But why does it happen? It happens in several ways. One reason is because patients don't talk about sex. Doctors, they are so busy, and the emotional barrier between the patient and the doctor is usually so big that the patient is scared to bring it up. Besides, the patient is feeling a little bit ashamed. I should be happy that I'm still alive, so forget the sex. That's what society thinks, so I'm scared to talk about that. That's at least one part. Besides, if you have a sexual problem, is it from the cancer? Is it from your mind? Is it from your partner? I don't know. So patients don't talk about. At least 85% of the patients doesn't, oh, wait a moment, doesn't talk about that. Now, what about the professionals? Talking sex, many of us are scared to do so. We don't know what to ask and how to deal with it. And it is what you see already in medical students, in interns, when we tell them you could discuss it with the patients, then many say, yeah, but imagine I ask questions about sexuality. Imagine there is a problem. And that's not, or maybe it is very different from what you do in other things. If you're a GP and a patient comes to you with complaints about the belly and suddenly you think, oh, wait a moment, could be cancer. Then you don't say, oh, I shouldn't go on because maybe it could be cancer. You have to go on. And why not do the same with sexuality? But that's, in a way, it's a little bit difficult. And it really is difficult. You can see that here. It is in a group of gynecological cancer patients, in 62% the topic had not been addressed. Now, of course, gynecological cancer is not real a sexual cancer. It has nothing to do with sexuality. But in most of your cancers, it's more important to know. So you will have better numbers, I think. Good. What I want to do is for the majority of you to change after today a little bit in your approach to looking at cancer. And I've tried to do that in kind of a graph. When you have a disease or when you have a sexual dysfunction, then usually we look back and we look what kind of causes are there? Is that a biological, a psychological, or a social cause? That's with the biopsychosocial or biopsychosocial cultural approach. That is how you look at a given complaint. If a woman says, I don't have sexual desire, you're going to look, is it hormones? Is it the relationship? Is it her upbringing by her mother? Is it her religion? You look into the different things. That's a way of a causal way. But you can look also in a different way, and that's maybe more important for us. If you have a disease, how to continue from that moment. And then you can look into another way. You can look, and that's what we do more and more in cancer, we look, what does this disease do in your sexual function, in the machinery, in the desire, in the erection, in the orgasm, in the lubrication, in the satisfaction. What does it in the function? And another one is, what does it in identity? Feeling male, feeling human, feeling female, that's much more an identity thing. That's different from function. And the third one, what does it do to the relationship? And this way of looking from disease to these sexual or identity effects, that's the way we all have learned in the medical field to do that in other areas. If you get, for instance, a patient, it's winter and the patient is fallen down, has broken his leg, and it's an open wound, you get infection. And you know, here is the trauma. What can happen in future? She can get or he can get an infection. So we have to take care for the infection. We have to give antibiotics because we look forward from this moment to then. And in a way, we don't do that in sexuality. If somebody gets cancer, it's not common to think, patient cancer, breast cancer, what will it do sexually? Or prostate cancer, what will it do? In prostate, we think already about it because we all know that erection can go. But in many cancers, we just simply forget to think about sexuality. We think about food, about diet, about other things in life, but not about sexuality. That's what we maybe have to change. That it's kind of an automatism also to think about sexuality. It's a proactive responsibility because the patient is scared to do that, to talk about that, so we have to take care for that. That's our responsibility. It's not a cure, but a care responsibility. And of course, there is interaction between the things. If your function isn't doing well, it can affect identity and can go all around, and directly affecting as well sexual activity. If you don't have a good erection, you can imagine very well that it's difficult to start a sexual encounter with your partner. And that's what many men are doing. It's for men quite difficult, if you know I can't finish the job, to start petting with your partner because maybe she will get excited and then she wants to be fucked and I can't do that, so let's stop it. And he simply doesn't start, or he refuses to play with her. Good, here you see a little bit about identity. It's a young, beautiful woman. And imagine how to go back into your bedroom when your body has changed in this way after the surgical intervention. That does something with her identity. And of course, it can have effect on her sexual behavior and on her partner relationship and on her partner's behavior, etc., etc. Okay, I want to talk a little bit about male-female differences. It's not only anatomy, there is a bit more than only this. I love these pictures because the way they look, the boy, he's so curious, and the girl is more looking careful to him. So here already you see that there is difference more than only the anatomical difference. How does that happen? Everybody of us, we start independent if we are XY or XX. We start in the womb, early in the uterus. We start in the same way, and we can continue in the same way and become a female body with a female appearance and a female mind if you don't put something additional into it. For everybody, the body makes us prepared to become a woman. If you become a woman, there is something already in your brain which makes you more female than what happens in the typical male. And the more female is more trying to be in relation to other people and more trying to be nice. I see this already in my granddaughters, 2 of them. They are really like this, always taking care for the surrounding. But after about 8-9 weeks of pregnancy, then the male body, the very little tiny male body, this size, is starting to produce testosterone. And the testosterone goes down to the sexual machinery, and then you get the Müller and the Wolff's tract. They change into the urological different system. But what happens, I guess, for the sexologist is even more important. It changes also his brain. The brain of this very little boy is kind of marinated in testosterone. And this little brain is already very different the moment when he is born. And nowadays we can do research and we can test the reaction of very little babies the day after they are born, and it's not the influence of pink or blue or what father or mother is doing. It's real what the hormones do to the brains of the children, and the boy is already, I want to be independent, I want to be autonomous. It's already very early in life, it's something for the boys. So that is long before we can do any additional education, it is already there. If you have male and female children and you don't understand the difference, read those books of Louanne Brizendine. She is an American brain researcher and psychotherapist, and she very clearly explains the different brains of the little girl, the older girl, the little boy, the older boy, the grandfather brain, etc. Now, some typical male-female differences, the way I think it goes in the majority of bedrooms in sexuality. Men are more oriented on what we call in our Western culture sex. That means more on the genitals, more on performance, on penetration and on orgasm. There's nothing wrong with that. That's malish. That's what biology tells the man. The woman is more oriented on relating, on contact, on sensuality. That doesn't mean that she never wants sex just for the sex. It happens once in a while. It happens, for instance, in the middle of the period when the LH goes up, and when you don't use hormonal contraception, then in the middle of the period you get a peak in LH. That means a peak in testosterone. And we know now, if you do research on women and you ask them, they did that in one of the discos in Vienna. They asked girls, do you have hormonal contraception? And when they didn't have hormonal contraception, they took a little bit of the saliva and they put them on a little thing, and then there was a machine, and the machine was taking a picture of how she was dressed, and the computer could measure how much naked, how many open pieces, how much skin you could see. And there was a very clear connection between the high testosterone levels and more nudity. That's the way that biology tells you you have to get pregnant, because our evolutionary task is to get more children. So there are some moments, but in average, the woman doesn't have that much desire. So she's more in trying to be in contact. But this is not all. There is more into the man, because we are also more assertive. Assertiveness is dependent on the amount of testosterone. For the oncologist, especially the one who's treating male patients with prostate cancer with anti-androgen treatment, one of the complaints of the man is they lost their assertiveness and they lose oral fights with family members, for instance. One of my brothers-in-law, I have 3 brothers-in-law with prostate cancer. One is on ADT treatment, and he was a professor in the University of Utrecht, and he was really the powerful one in the family, and he completely lost the fight with his sister 2 years after he got his treatment. Internal things change, but the normal man with his testosterone is much more assertive. And a normal man doesn't have very good sensories for what's going on. When I'm on a party with my wife, she knows within 15 minutes who's doing it with whom. And I don't have the faintest idea at the end of the evening. It was really different, even if it's my job. Now, what is the female, you could say the counterpart? Women are quite submissive, and I don't mean that in a negative way, but that fits more to the female character. And she's more sensitive, but what is also very important, she has more feelings of sexual guilt. And that is very striking because I haven't always been only in medical sexology. I've for a very long time been in what we call common sexology. And we had from 1982 to 1995, I've been very much involved in sexual abuse, sexual violence, rape, and incest. I have seen 700, 800 women who had been raped or abused by a father or grandfather. I remember 4 or 5 of them who did not feel guilty about it, and all the others felt guilty. So it seems as if in some way women feel much more guilty about sexuality than men. I don't know if that is true for the youngest generation, but at least for the majority in my country, this is reality. Now, if you put this together in one bed, which happens in a lot of heterosexual relationships, that's asking for problems. You don't need cancer for that. But if we add cancer, and happily enough, the majority of people are more and more adapted in a way to each other before they get the cancer, because usually it's an aged disease. So it is not better or worse to be a woman or a man. It is as it is, and we have to live with that. Now, it makes girls more people-oriented and boys or men more thing or function-oriented. These are 2 of my granddaughters. They have been standing like that and chatting like that for half an hour. And those boys, it's not my grandchildren, but they have been there for about 1 hour, and all they say is shouting, "Screwdriver! Left!" That's all. That was enough for them. It's not better, it's not worse, it's very different. And finally, they have to come together in bed. So that's the job of the sexologist. Now, what happens in case of cancer? If you put a man and you let him get cancer, or a woman. Now, for the women, when they get cancer and they get treatment, after that they are more than average busy with restoring the relation with the partner. That means she's concerned about desire, not about her own desire, but desire for him in a way that he can go on with his male life. And she has problems with disfigurement, with changing of the body. That's important in average for the woman. What about the man? He's not worrying about desire. He's worrying about function, about erection, or about orgasm. And if his wife is having cancer, he's not worrying about other things, but worrying about her orgasm. So he's doing his very best to give her an orgasm. That's the job. We should be a good lover. So we are doing like that to give her an orgasm, even if she doesn't like. But we don't understand. The majority of men don't understand that very well. Now, oh yeah, I didn't put it in here, but maybe I can tell you. If we go back one, up there, no, up there. Anyhow, if you look to the same perspective of how a male worrying about and female worrying about. Female worry about relationship, male about function. What about oncologists? If I look around, I see nicely 50-50 male-female. No. Who is the surgeon here? Who are the surgeons? Oh, it's a male, a male, a male, a male. Ah, that's funny. That's function. It's not strange. That's the way we are. And the nurses, are the male nurses in the room? Female nurses, of course. But it's not abnormal. And it's not emancipation and all that kind of stuff. It's basic in our biology. So don't feel ashamed about that. That's what nature told us to do. Okay, worries about the male. For instance, the male, well, this happened from, I think it's from Holland, but I'm not sure. For a lot of men, when they get prostate cancer, when they worry about what's going on, they don't go to the doctor. We don't want to deal with that. We just want to continue our job. Quarter of the men went to see the doctor because his wife told him, go to the doctor. Not because he wanted to do that, but she's going there. And then he gets a diagnosis of cancer. He was not worrying. She was worrying about his body. Other men, if they went to visit the doctor because of their worries about prostate cancer, 10% of them didn't even tell his wife. Isn't that a bit strange? I don't think that many women will have this kind of behavior. It's a bit malish. And if possible, also, if men get a sexual problem, they don't want to bring their wives. That is, no, it's my problem. I shouldn't bother her with that. Typical malish. Female and worries. Female feel guilty about having no desire. And here it's very important, if you talk, that's a thing. In sexuality we talk about desire, and then the next is the excitement, the arousal, lubrication or erection, and then you get orgasm and satisfaction. But in desire, and in my language, in Dutch, and the same in fact in English, we don't have a very good words for absence of desire and I don't want you. Most people have absence of desire. Is there anybody now in this moment in the room who has sexual desire? Okay, that's absence of desire. There's nothing pathological. Yeah, okay, good. But that's completely different from people who say, I hate him. I don't like it because I was sexually abused. And that's much more a mental problem going on in your mind. That's not physical. That has not to do with cancer. It's the absence of desire. And of course, this absence of desire, that you will see that very frequently in cases of disease or treatment. That belongs to the physical thing. That's clear? So keep that in your mind. That's important. Another trap for the male, when I explained this already, when he is afraid I can't continue, he stops doing anything. And they found that in the United States research, they found that 41% of the wives said, my husband doesn't do anything, he stops all intimacy since he has an erectile problem. So that's part of the typical male sexual responsibility. Good. Now I want to talk a little bit about sexual function. How does it work? I give a tiny advice. This evening, when you're home, or this weekend, don't think about making love. How does it work? Because it will not work when you think about it. It goes by itself. It's biological machinery. But as a professional, you have to know a little bit the different functions. This is the common way: desire, excitement, and orgasm. That's clear? Everybody understands this? Do you recognize yourself in this graph? Is this male or female? Are you sure? I think now it's more clear. This is the black hole. The egoistic male, as the feminism said some years ago. That's purely when we are ready, in Dutch we call it when you are ready, then you go deep and you can't do anything. Even if your wife brings 2 girlfriends and they have a beautiful striptease, you are completely out of the system. It has to be regenerated. It's the refractory period. That's typical for the male and a little bit for some female orgasms. This is the man, the average man. And of course, again, like I told in the beginning, sexuality is different. Of course, also men are not always the same. To explain a little bit, if this is a graph on the length, the tallness of man, here you have the man, here you have the woman. But of course, there are couples where the woman is taller than the man. That doesn't mean that there is something wrong with that man or that woman, but the average man is taller than the average woman. The average man is stronger than the average woman. The average man has this kind of sexual machinery. It's kind of a linear process. First we have desire, and we have a lot of desire because we have a lot of testosterone. And then we want to, if possible, we want to continue. When you're on steam, you want to continue. That doesn't mean you're forced to do that, but your biology tells you, if possible, go on. So we try to be nice for the other in the way that we can go on. And then we have a rather fast orgasm, which is the truth for about a quarter of the men that they have premature ejaculation for a period or for their full life. And then finally, we go into orgasm, and then we fall into the black hole. That is reality for man. That's the normal way. Now, what is different in the woman? In the woman, usually she doesn't have all this desire. She, like we all have, no desire here. But when you go home and you are in a heterosexual relationship, the man with all his testosterone, he wants to have sex. So he's in a way nagging and trying to get her into sex. And she's still busy washing the dishes or with the children, so she has no desire yet. So in most relationships, the woman starts not with having desire, but if he plays the game a little bit nice, she's getting excited even before she gets sexual desire. So this process 1, 2, 3, which we always said up till 10 years ago, that's the reality for men and women. We have realized now that's not a reality for women. For most women, it's first you get an amount of excitement, and then you can get desire, and from the desire, if you're lucky, you can go on. And then you can go on to orgasm. Again here, a difference. Orgasm isn't that important for the women. For a lot of women, they don't need that orgasm in the way men need it. That doesn't mean that it's not important, but the timing is so different. That's for me. No, sorry, that's for men. It's difficult when the woman says one night, oh, I love intercourse, but I don't love orgasm. And another night, she loves orgasm, but not intercourse. And then she doesn't love both. And then she wants... I say, but it's nice. Why don't you like it? It's because she is so completely different from him. Why? Because she has a monthly period with different hormones. She's pregnant. She has so many connections to the outside world. She's multi-focused. And I'm focused on one thing. When I'm on my job, I'm on my job. I'm not worrying about the children or my wife. I'm on my job. But for her, she's always having these connections. And I understood that that's for the majority of men and for the majority of women. This is not better, it's not worse, it's the way we are. And we have to deal with that in sexuality. Another way is orgasm isn't that fast in women. Because women are a bit slow in getting orgasm. That's at least what we told, but that's not real true, so I have to show you something. A little Dutch invention. Some of my colleagues They are inventors, and they invented this new Dutch vibrator. It's very small, it's a very tiny vibrator. Here it is. That's all, that's the vibrator. You put it on top of your electric toothbrush. And it's very strong. It is very strong. The funny thing is, when they put it out in a group of women and said, please, could you try, what do you think about it? So a group of women took this vibrator, took it home, and reported back, I had an orgasm within 2 minutes. Wait a moment, within 2 minutes? How possible? That's of course because this is much stronger than what he has down there, or there, or there. So that's one, this is strong. But the second is because the woman, when she is in a relationship with her male partner, the male partner with all his testosterone is trying to get her into sex and into an orgasm. It's not on her moment. When she's trying to do this, she at a given moment, she has done all her things, and then she gets into the mind of sexuality. So here she's ready before she starts trying this. And then 80% had an orgasm within 2 minutes. And of course, 2 minutes, how do you know 2 minutes? Are you going with the timer? Yes, but there is a timer on electric toothbrush. It stops after 2 minutes. So and we realized afterwards, so fascinating. Good. So that's and another piece of difference is, and here for the man, we have to be a little bit humble. If we get an orgasm, it's finished. If the woman gets an orgasm, a lot of women have learned, oh, it's nice to take another one, to take another one. And then you can get that. It's because you don't have this refractory period, at least the majority of women. Some women do, and that's for those of you who are working in gynecology, there is a difference. If I don't have that on slide, but if you look into the spinal cord, you have centers for orgasm, and one center is in T12, L2, and that's the center for the male to get the sperm from the epididymis and the vesicula into the prostate gland, and from the prostate to contract and put the prostate fluid into the open area. That's step one. And then you have S2, S4, low in the spinal cord. That is the level for contractions of the pelvic floor. And in man, it goes normally in in a train from 1 to 2. In women, it's evolutionary. There was no reason to build up that way. So it's a little bit a side effect of the male evolution that the woman can have an orgasm. And then you have the lower part of the orgasm, the S2, S4 orgasm, is the pudendus nerve, is the contractions of the pelvic floor. And that is for what most women can do. More or less 90% of the women can get an orgasm just by the clitoris, with this machine or the vibrator, or with her fingers, or in another way. That's for most women the normal way. That's S2, S4. If you go to the higher level, part of the women, about 25–30%, can get an orgasm by banging to the uterine cervix or to the G-spot, which is the frontal area of the vagina. There seems to be a very sensitive area, and if she's stimulated in that place, she gets an orgasm which goes through different nerves, splanchnic nerves, to T12, L2, and back to contractions into the uterus. And we believe that for most women, if they have that kind of orgasm, they have also the refractory period, and then it stops. But that's more complicated physiology. Good. What do you need for desire? Which is, of course, a very important area. You need enough testosterone. And you need also good balance in your neurotransmitters, the dopamine, the prolactin, and the serotonin. That is one of the big damages what we are doing nowadays. I think many of you will give patients or have patients who are using SSRI antidepressants. With the SSRI antidepressants, and nearly all antidepressants, you change the neurotransmitter balance. And if you get a change in that balance, you can have consequences for sexuality. In my country, the most frequent given antidepressants are the cipramil, citalopram, and the paroxetine. In Holland we call it Siroxat and cipramil. If you have that, 50% of the people cannot get an orgasm. It goes completely away, 50%, half of the people. But it also influences your lubrication or erection, and it can influence also your desire. So this is important, and especially the dopamine. People who get dopamine, for instance, in Parkinson's disease, they can get very high desire. But most important in oncology is testosterone, because we are doing a lot, changing a lot in the testosterone. Here you see the male testosterone. It starts in puberty, and then it goes slowly, by 1% goes down in a healthy man all over his life, so that when he is 95, he still has enough to love sex and have good sex. What about the women? Also, the women have testosterone. That's a big mistake in many countries, that we have too strongly adhered to the testosterone. That's a testis hormone, so it's male hormone, it's called male hormone. And that is, of course, crazy, because women have it as well, and they need it as well. If you don't have testosterone, a lot of things will change in your body. It goes also the other way around. If you are real in a sexy mood, your testosterone can go up, and if you fall in love, and you are real falling in love, in a woman, the testosterone goes up about 50%. People who are real in love. You know why? Because when women have more testosterone, they want more sex, and that's typical the way to attract men. So we men like sex, so a woman with a higher testosterone, that's good for the man. So in evolution, that's the way to fall in love. You know what happens to the male? Testosterone goes down, because then we are a little bit more nice for the woman. We say, I love you, and we bring flowers, which most of us never do afterwards. Okay, that's what testosterone is doing. In women, you start already at an early age. When you are about 8 or 9 years of age, you get already testosterone from your adrenal glands. That's what they call the adrenarche, when the adrenal glands start making testosterone. That's why 10% of the women, of the girls, already masturbate before the age of 10, because they have this high level of testosterone in their body. And then you get into puberty, and in puberty you will get another 50% of your testosterone. And then it goes on till you get into the menopause, and then where the estrogen hormones, they go very strongly down till 0 in the menopause. This takes probably more time before it has gone completely. So the changes are much slower. Now here happen, for those people who are dealing much with hormones, in this period other things change, because your estrogen hormones who suddenly go down, the estrogen hormones keep the SHBG on a high level. SHBG is kind of the taxi for the sexual hormones. So when the SHBG is high, the testosterone which you can use is low. Now when the estrogen goes down, you have much less SHBG, and that means that some women in the menopause get more testosterone. You see that some women, they get a mustache, they get more fierce into society, and they have higher desire also sometimes. For some men that's nice, for others it's threatening. So this is the way of the testosterone in the woman. Is that clear? Are there any questions on that? No? Okay. Here is what you see, what you need it for. You need it, of course you need it for sexual desire. You need it, the ability to get aroused. That is what is in the brain. You have cells in the brain, receptors in the brain, where you really get horny. You need testosterone in your brain. The possibility to get an orgasm, maybe that's connected to this arousal in the brain, your assertiveness, your physical strength, your general well-being and your good mood. In Holland, we did a population research on depression, and between 18 and 65, a Dutch woman has a 20% risk to get a depression. In men, it is 11%. And 30 years ago, we should have said, yes, that's because of the social position in society. And then we said, no, it's because of sexual abuse. And now we know it's most probable. It's just the result of the testosterone. We can treat some depressions just simply by testosterone. In other words, testosterone is very important for the woman also. And then we get into oncology, because our treatments very frequently influence the levels of the testosterone. And of course, this is very medical. The bone mass and the muscle mass, they go up, and the SHBG, they go down. Now, why do people have sex, and why do we have to talk sex? Why is discussing important? And why do people have sex? There is a nice book. It's a group of researchers in the United States, Cindy Meston and David Buss. They put this question in a big group of people, not patients, people, and they got 237 different arguments to have sex. And the funny thing is, in my work with chronic patients, people with physical impairment, people in the last stage before they're going to die, they have another range of different reasons why they want to have sex. And of course, when I say why people want to have sex, it's not only why they want to have intercourse. There are different things you can do in sexuality. Sex is more than only intercourse. It's the same if you talk hormones. It's more than only intercourse. It's also feeling male or female, thinking about it, imagining yourself standing in front of the mirror and saying, wow, look my. That's also sexuality. That has also to do with hormones and with cancer. The average arguments, of course, is relation. That's what usually women have to say, out of love. If you're very young or just married or very religious, you have to say it's because of getting children. Men used to say it's because of recreation, fun, whatever you want to call it. But we have to be real to realize that the majority of sex is because we did it also last week after The Bold and the Beautiful, or last week on Sunday morning, because people are also custom animals. And that has, you can look to that in different ways. In one way you can say it's not very romantic, but it's very healthy. Because if you have more sex, it is more healthy for your body. That's not what all doctors see, because we had 2 years ago, there was a very big meeting in sexual medicine, and it was asked to the audience, what do you think? Is sex a healthy or an unhealthy act? And even those people from sexual medicine, and the majority of them, they started with impotence research. That's the way they got into this area. The majority of them, they believed that sexuality is not healthy. And that's a very typical malish medical way of thinking. It's not thinking about health, it's thinking about disease. They see the results of unwanted pregnancy, of sex in pregnancy, in sexual transmitted diseases. They see it in cancer, which you've got through sex. But of course, there is much more sex which is directing us in a positive way. I'll come back to that maybe later on. Oh yeah, here it is. It is emotionally relaxing. It can decrease the tension in a couple, and there can be a lot of tension if one of the two has got cancer. It can restore disturbed intimacy. That's important, for instance, if we are dealing with a woman who usually is not naked, and now she's getting cancer, and she has to be examined in the hospital. And she's laying there with her legs wide and the doctor with his coat on, and then a young doctor comes and a nurse comes in. Her intimacy is completely gone. And for some women, they need sexuality just to restore this intimacy, to get the doctor away out of her system, or to get the medical things away out of her system. Then she can have sex. But in another way, we have to be careful that what we do also influences this intimacy. It's very having so many emotions, and heavy emotions can be gone down a little bit by sexuality. It gives also muscle relaxation. That's what I learned in physical rehabilitation, people with spinal cord injury and people with MS. And we know now in research that the muscles are much more relaxed for 6 or 12 or 24 hours after sexual excitement and after orgasm. And even your bladder function in spinal cord injury is better. We know also that it increases pain. Everybody of us, if we do something which distracts our mind, then you will have less pain. If you look at a good soccer match or a romantic movie, you forget your headache or you forget your monthly period ache. And the same is with sexuality. For women, there is something additional to that. If you stimulate genital, especially if you stimulate the uterine cervix and the anterior part, the G-spot part, then the pain threshold really goes up, and we can measure that in the lab, it goes up. It's kind of evolutionary development in the woman, and it has developed through the system of delivery. When during a delivery you have too much pain, the process stops, you don't continue. Now the woman with many of those receptors for this, how do you call that? It's not a good word. Where you give the signal that there is pressure inside the vagina, that signal is gone to the brain and you make endorphins. And those endorphins bring up your pain threshold. And now we use that proactively in physical rehabilitation. Instead of accepting, I have pain, so I don't want sex. If you have pain, you could change it by having sex. And then, of course, you have to make a slight difference between the function, the romance, the religious connection to what you have to do. Because now it's just only the function. And that can be done by an internal vibrator. You don't use that one because you can't put it inside. But you can do it even by stimulating the clitoris or stimulating inside. So you can use sex even to get less pain. It's a good sleep medication, which can be very important in a hospital as well. It decreases vaginal atrophy. For those of you who are not yet in menopause, if you want to prevent getting atrophy in menopause, the best what you can do is have regular sex. Now, regular is not a good word, because once a year with Christmas is also regular. But I mean, in another way, regular, frequently, more frequently than average. If you do that, you have much less risk when you get into your menopause to get vaginal atrophy. And it gives oxytocin. Just simple massage gives oxytocin. That's what the mother does with the little baby. Oxytocin is the hormone of lactation, but is also the hormone of connection. And if you have this real sexuality with this touching of the body, what people working in physiotherapy, they know that sometimes men start to talk when they are laying down relaxed with a physiotherapist, because we don't open up that easy. But after getting high oxytocin, we do. And that's what a lot of men do when they have got an orgasm. After that, they can talk. A real evolutionary trick is that in women, it's the other way around. They can't have sex if they did not talk before. Okay, that was not clever from him up there. Good. More reasons is because for many patients, sexuality and intimacy are very important parts of their quality of life. And of course, we have to take care, because it's our interventions which did the damage. But let's be clear. Cancer in itself doesn't damage so much to sexuality. If you're in a late stage and you get the complete devastated body without muscles, then it has effect on sexuality. But the majority of sexual problems get by our treatment, by the radiotherapy, by the chemotherapy, by the operations we do, the amputations. We are doing that. So we have to take care for that. I hope that's clear. That's our responsibility. Discuss it with all patients. That's of course a question. Yeah, but not to everybody. If you're real old, if you're single, if you're gay or lesbian, in culture, if it's different, are there reasons not to talk to the people? We believe it should not be arguments. Everybody has or can have sex, and you better first inform before you say, no way for us here. Advanced age, it's a funny thing. In young age, sexuality is much more performance-driven. That's, let's say, male sex. We want to do the real thing. If we grow older and we have a little bit less testosterone and maybe we have to use a bit Viagra because we didn't have the good lifestyle and we get erectile problems, it becomes less. For the women, it becomes more because at older age it gets more intimacy-driven sexuality. And that's more the female sexuality. So if you, in some research, we find that at the higher age groups, a higher percentage of women than of men tell that it's very important for them. So for both of us, could be nice to think about the future. About your sexual orientation, gay men and cancer, are they different? Do they have different cancer? Of course, we know people with HIV, they have more risk for Kaposi sarcoma. When they have HPV, and they have, of course, much more HPV, it gives more oral cancer, more anal cancer, and more penis cancer. In anal cancer, we don't know exactly, because in Holland, where we have a quite big gay community, we have more anal cancer in women than in men. And we don't know, is that because more and more women are having anal intercourse, or is there something else? We don't know yet what is the reason for that. And you have more hepatitis B virus and hepatitis C virus, so you have more cancer in the liver. But at the same time, they have a better lifestyle than the average heterosexual man, so we don't know what influence that has on other cancers, because lifestyle, food, influences also a lot of things. Now, what about the women? They have less risk to have HPV, so they have less cervix cancer. Now, I'm talking about the pre-vaccination groups. But you have to be careful, even in what they call the pure lesbian women who never had sex with a man, they found HPV. Because HPV is very easily brought from one to the other person simply by fluid. You don't need the real sexual contact. Just if you have crotch against crotch, what a part of the lesbian women are doing, you can give already the HPV to the other person. So we have to be a little bit careful with that idea that when she's a virgin, she can't have cervix cancer. They have a different reproductive history. The majority, I think the majority of lesbian women didn't get children, didn't use oral contraceptives, so didn't give lactation, and that gives a different group of cancers for them. They get more ovarian cancer, more endometrial cancer, and more breast cancer. And that is a reality which a lot of lesbian women and lesbian physicians just simply don't want to know and to tell to the community, but it's reality. And they have a different lifestyle. The average lesbian woman is smoking more, has more overweight and more alcohol consumption. That means also, again, the overweight gives more endometrial cancer and more bowel cancer. So this is reality. You have to think about that. And I understood that in your society, being lesbian is not a point to tell to your doctor, but doctors should know the consequences of what it can do to cancer. About the palliative stage, is that important to discuss about that? This is one example, and I've seen, in the meantime, I've seen a lot of them. It's kind of a hobby, but hobby is not a good word, piece of interest of me. Long ago, more or less by accident, I asked the man about how was it when your wife died. His wife died of cancer, and he came with a new partner. And a lot of men, when your wife has died, and then you get later on, you get a new partner, they have a period of impotence. They call it the mourning impotence, because you lost your partner and a new partner, you have to adapt to the new partner, etc. So more or less by accident, I asked him, how was it then? And then it was very funny, and I've heard it again and again. People can talk very easily about it, even if the new partner is sitting there, and they are happy to talk about it. So I continued to ask, and then I discovered again this wide range. Some people stop completely, don't do anything. Other people have a lot of cuddling but no genital sex. But other people, they have more sex than they ever had in the past. Maybe not in the beginning when they were falling in love, but after that 30 years of relationship, they didn't have that much sex as now in the last months, which is very strange. And that's again, why do people have sex? That's an important area. And then maybe it's good to tell that. Is one of my colleagues in Holland, she's doing research, not retrospective, what I did, but real asking to people who are in the last stage of either cancer or muscular disease, the amyotrophic lateral sclerosis, ALS, where you die within some years. So she goes to the couples and she discusses with the couples, and she explained extensively to me. And for me as a sexologist, I take out 3 questions. One question was, did they ever ask you about sexuality? And the answer was, for all people, no. The second question was, how was it with sexuality? And then you hear the wide range between nearly nothing to a lot. And the third question was, and that was the most intriguing part, what if they had asked you, or what now when I ask you this question? How is that? And everybody said, I'm very happy with the question, even if they had no more sex. And then you have to think, why is that? And that has something to do with identity. That's not a function question, that's an identity question. When I get this question, I seem still to belong to the living people. I still seem to be a woman, I still seem to be a man. And that is so important. So for all of you scared, when you are scared to discuss with your patients about sexuality, when you do it, you give them a little present, just simply by asking the question. So that makes it maybe a little bit more easy to open up. This is what we learn from those people in the last stage. I explained already a little bit that it's not so much the cancer, but the treatment, the battle against cancer, what causes the damage. Now I'll give you some examples. Oh, time is running. I'm talking too much. Sorry. Breast cancer first. This is the way that you all have to know how that goes. 70% is stimulated by hormones, and then you give tamoxifen or that kind of stuff. And then this is more or less a simple scheme for how we deal with breast cancer. Now you can put that in this way, all the different treatment approaches, and look, what does it do to the different functions, to the identity, to the relationship, and to very specifically sexuality. For instance, in sexuality, if you remove the breast, you remove in some women the erogenic zones, but not in all. Because somewhere in the range of 10% of the women, I don't know exactly, lost that number, but it must be somewhere in the range of 10%. They are not sensitive and they don't like the breast to be part of sexuality. But for other people, they can't get an orgasm if the nipples are not stimulated. So again, a very wide range. And there's nothing wrong if you don't feel, there's nothing wrong if you need the nipples, but it's reality, and we have to take care. So if you are dealing with breast cancer, try to get this known how it is and try to put this inside your scheme of report. Again, this is lymphedema. This is a serious lymphedema. Imagine, this was the normal arm. If you have such an arm, you can go into society. But if you have that arm, what will it mean? You immediately get a reaction, the common citizen reaction, oh, she's not very clever in her mind, that kind of woman. And she just had only breast cancer. That's complicated for the woman to go back into sexuality. Or imagine she lost her partner or she doesn't have a partner, to go dating with such an arm. That's a real difficult thing. Here you see some examples. And now I better do that now because I will forget it. These are pictures from this book. I will give it to those people. Let me give it to you, or I don't see the other person, but this is for your group. This is all on decisions on what to do with your breasts after you've got breast cancer, with a lot of marvelous pictures for women to look what can be the consequence of treatment or no treatment in this way. Okay, let's go to the male. The prostate cancer. Again, the scheme, how we deal with that. If you are living short, we do the wakeful watching. If you live long, we do surgery or radiotherapy. And then you can give androgen deprivation and all kind of stuff. And then you give the chemotherapy. Again here, you can put it in that way that you look what is going on now here. And then this is just, I did it day before yesterday with my wet finger. But when you are in this area, you better have this scheme and try to find out from your patients and from your own mental exercise where do you have to give attention. Let's go to ovarian cancer. This is the healthy situation. You see the uterus, you see the ovaries, you see where the testosterone comes from or the androgens from the adrenal glands. So this is the normal way. And now you get cancer. And now what we do, we remove the uterus and we remove the ovaries. So you've lost half of your hormones. So you have no estrogens and you have only half of your androgens. But we do something else. We give chemotherapy. And chemotherapy goes as well to the adrenal glands. And then we have also from the adrenal glands, we have less androgens. And then you get the full range of androgen deficiency in a lot of women who have both the steps of removal of the ovaries and then next give chemotherapy. The trouble is, very few people in the world are doing research on this, and we have not the faintest idea what's going on here, if it's coming back or not. We just simply don't know. Now, what I've understood that you've got a lot of problems with Iceland over the last years, and the name of Iceland has gone down very much. If you do this kind of research, you can get back into the world. Iceland is doing a real thing. That's just a simple take-home message. About the blood lymph cancer, we all know people have fatigue, people have low sexual desire after this, and a lot of them has also disturbed fertility. The women have no more period or very irregular period. Now, what is the connection with sexuality? Chemotherapy does more or less what happens in ovarian cancer. You damage both the ovaries and the adrenal glands, and you diminish the amount of androgens available. So that can have influence. And then we should realize that both fatigue and low sexual desire can be a result of low testosterone. but it can be also the result of other things. So what is important is if you get a patient who tells us, I liked sex very much, I loved it to have sex with my husband, I loved it to use my vibrator and masturbate, and it has gone completely. That's the patient where you have to think about hormones, not the woman who never liked sex very much, and okay, I agree, if he real once and he is a little bit nice, and then he started with the foreplay already with breakfast, and then she was okay to do. In that woman, if she has low desire after chemotherapy, you don't start to think, oh, most probably that's hormones. So again, you have to fine-tune a little bit also your history taking, what kind of person is behind this problem. And then you get, for some people, they get a total body irradiation, and then included with the allogenic transplantation sometimes, total body irradiation can do the same also with your hormones. And then what is important for those people who work with allogenic transplantation, especially for the urologist and the gynecologist, you can get a graft versus host disease, which can damage the penis and can make intercourse very complicated for the man, or can damage the inside of the vagina. That the vagina is not more a tube like that, but like that with adhesions and stenosis in the vagina. And we have to, there are treatments now for this graft versus host disease in the vagina. Okay, and all together you will get, here lies our faithful sex life. So that's our responsibility. Then what do we do? So you can refer them, when it's real heavy problem, we refer them to the medical sexologist. And we have, these are different things which we have in our toolbox. We have tools, toys, medication, dealing with side effects, relationship treatment, etc., etc. So I thought I put this one in as a last kind of an algorithm. How should we deal with sexuality? The diagnosis, and then you give treatment. When you give treatment, please include information on the possible side effects and indicate that we have solutions. And you do that again at the end of the treatment, before they are discharged from the radiotherapy scheme or chemotherapy scheme, or before they are discharged from the hospital. And then in the follow-up, just simply ask, any changes since the treatment, any changes in your sexual function, in your intimacy since the treatment? Because we have done a lot to your body. Take responsibility and tell, we did it. Of course, you can get the answer no, then it's ready. If you get the answer yes, the next question is it bothering you? Because some people get a change in function without having problems with that. But if it's bothering, then you can refer them to sexology or in another way, but then you have to deal with it. I hope that is clear. It's just a very simple scheme. If you all follow this scheme, your patients will be happy. And in the meantime, I think, take care that you have a lot of things on paper, because what you talk to the patient when they just got a diagnosis of cancer, they just forget it immediately. These are some of the books you wanted to know. I'll drop that. You will get this presentation. I leave it in Iceland so you can see that. That's I'm over my time. Sorry for that.
Thank you very much for your talk. I'm a urologist, so I might be thinking a little bit more mechanically about these issues when we talk to male. Also, it's the question of timing, how you approach this, and I usually, when I talk to the couples, I like to put it in a way that you deal with the cancer first, then the incontinence, and then their option because of the erectile dysfunction. I mean, in some way you have to, for practical purposes, you have to.
Yeah, but that's not one thing is very good already. You start with talking to the couple. It's because don't talk to the man only. It's never talk to the patient without the partner when it's on cancer. That's one. But at the same time, you think about one. Cancer, staying alive, incontinence, sexuality. And for part of the man, it's like that. For part of the partners, for most of the partners, it's the same. But a lot of men, the first question is, in their minds, what about sex? If I don't get an erection, you better kill me immediately. It's the question to the man who can decide what are we going to do. One of my brothers-in-law, he refuses any treatment because sex is so important for him. So that's before you make the first. The second is, when you start at the beginning and say 111, why not? And I don't mean the treatment, but tell it's important already to discuss sexuality and to take care now that sexuality after 1 year or after 2 years is not gone. And that's what we do now with the penile rehabilitation. We have schemes that already from early beginning, people are told continue in some way with sexuality, because if you regularly let your penis do its job by, if possible, getting it full of blood, you will have less trouble with the cells and the internal system in the cavernous body. So it's the penile rehabilitation, and nowadays some people say already after 2 weeks you have to start with the vacuum, or with every day, every second day, give a little bit of PDE5 inhibitors. But how to do that exactly, that's look into the Journal of Sexual Medicine.
Yeah, I did mention, I mean, a growing number of males are refusing treatment because of you discussed the quality of life issues, and that's another discussion. But also, you find it difficult to mix these together because men are so preoccupied with the cancer, I find, that the sex becomes a second issue.
Yeah, but anytime I should just add the 10-second question, is sexuality at this moment worrying? Because in 2 months we will discuss sexuality, but now we discuss it if it's important for you. If not, we just postpone it a little bit. But just mention it. When you mention it in the beginning, it's much easier for him to come back to it later on.
That's why I like to bring it up, even though I don't go into it, that there is...
Yeah. I think that's very wise. You had also a question?
Yeah, just I'm a gynecological endocrinologist, and I've been interested in hormone replacement therapy. And testosterone, of course, comes in. I love your video pictures showing the real problem. And how is the situation? Getting preparations? The pharmaceutical industry is not interested in this.
That's a real problem. I had in my university hospital, I had a group of about 40 women on testosterone substitution, and I had it prepared anytime again and again by local pharmacists, because it was not available in the through the normal way. And then we got Intrinsa, the testosterone, how do you call it, put on your skin. But there were so few gynecologists in the Netherlands who wanted to use it that they didn't bring it on the market. It is on the market in other countries, but not in Holland. But you have to find a way to get it inside your country. One pharmacy who will do it for all Iceland, that should be enough. Okay. Yeah.
Yeah, I'm another third surgeon, but I'm a breast surgeon. So I'm also very task-oriented as another surgeon. But the question that I have with regards to breast cancer is that I do a lot of mastectomies, and I also do a lot of reconstructions. Now, my belief has been that I'm in fact doing a lot of good things with regards to the body image of the women, and in fact hoping that in fact helps with their sexuality. The reality is that I get a little bit, because I'm relatively young, as I get more experience, I'm getting a lot of women who have a lot of sexual problems, in spite of the fact that I'm doing a great job with the reconstructions. So my question is, and it's just a sort of what your perception is, what is the true link between body image and sexuality? Because if there's no link, then probably, you know, shouldn't really be doing this many.
How many days do you have? It's a very complicated area. But what is, it is being a male, being a surgeon, being, let's say, reconstructive, a curing mind we have as doctors. We think, okay, that's the problem, so we do that, then it will be okay. I think if I was in your position, I should kind of, I want to have a second person behind me who is always before and after the operation asking the women, do you understand what he means? What do you really feel about it?
Well, that's an interesting comment, because in my clinics, I always have a nurse with me. Well, most of the times. And although I personally don't get a lot of information from the women about the problems with the sexuality.
But she will get.
Yeah, it usually comes through the nurse.
Yeah, of course.
So she comes after the interview and says, well, hey, there is a problem here.
Yeah.
And so, yeah, you know.
But women are so much more complicated than we. We have a straight mind.
Yeah.
And in women, that's different. A typical thing with breast cancer, mastectomy, is the fear of so many women. My husband doesn't want to have sex with me because my breast has gone. Now let me ask here in the room, how high percentage of the women do you think will be afraid that the husband doesn't want sex after 1 or 2 breasts are removed? Will that be in the 25 to 50% range? In the 50 to 75% range? One hand goes up. In the 75 to 95% range, then I think most will be somewhere there. It's very high. Now what about the male? How high will be the percentage of male who doesn't want to have sex because she has a mastectomy? Is that in the 25 to 50% of the males? Is it? Lower or higher? Lower. Are you sure? Much lower. It's somewhere in the order of 5%. Man, of course we like beautiful breasts, but it doesn't mean that we don't want to fuck. We are full of testosterone. And that's the message you have to give to your female patients. Don't worry about that. Men are so different. You have to tell it, of course, in another way, but but that's so different from the functional to their reality.
But is there any good link between body image and sexuality? Because you're telling me that it's completely
there are, of course, a lot of links, but it is, again, per person, very different. You see, even if you look around in the room here, for some women, image is so important. They have taken this morning about half an hour to get dressed up sufficiently to be present here. And for other women, they just put on something and they are there. So you can put it on in a one-to-one relationship. But some of the psychologists, but I think Jona, she will know more because I'm not a psychologist and she knows more about women, try to find something and explain that, because I don't have that, so 1, 2, 3 ready to answer.
How often...
Yeah, but I don't know if you're allowed, because
well, people are still sitting down, so we take one more question.
Don't worry to run away. I don't feel ashamed.
In regard to his question, when the female is worried about the sex thing, do couples talk about sex in general to each other? About
you mean do people talk about sex?
Yeah. Does everybody do it, or just a small portion?
No, I can hear that you are thinking now, are people different from me? That's, of course, we all think about that continuously. In couples, in people who are married for a long time, there are a lot of couples who even don't talk to each other when they have a sexual problem. And there are a lot of people who don't talk about sexuality. They just do it. They just hope that with my movements and my candles and my white sheets, I hope he or she will understand that I want sex, but just not simply asking and talking, because if I ask, maybe she says no. If I talk, maybe it's gone. So that's what happens in a lot of people. So real talking sex is difficult. If not in oncosexology, but if in sexology, in relationship therapy, if you give people the message, when you're at home, do you dare to tell your partner what you like in sex? I think that maybe 90% of us never has done that. It's very tricky, very dangerous to do that, because maybe she or he will think, oh, but that's, wow. Usually what people want is very normal, but that's the way we are brought up. It's difficult. So it's not so easy. So trying to get people talking together, that's what we do so much. We make the connection frequently through the therapy. And then what happens, and that's beautiful, I give an ID, and of course, when you give an ID, don't give the ID from me to you. If I tell you, you better use a vibrator this evening, when you use the vibrator, you're thinking of me. And I should stay out of your bedroom. Also, I should stay virtually out of your bedroom. I don't belong there. So what I tell you, I know with your disease that a lot of people have tried a vibrator, and for some of them it works. Maybe it's something for you to try also. So then it goes through a corner. It's a way of how do you give advice to people. But the funny thing is, if I've told something like that, in the car, when they are driving home, they are talking already about that. That goes very fast. Okay.
Thank you very much for your excellent talk.